The next session to chair, I request Professor Sukumar Mukherjee, past president API and past in ICP, and Professor Satyabroto Ganguly. He is our governing body member of Central API, also Professor of Medicine of KPC Medical College, and past chairman API West Bengal branch. Along with, I request Dr. Madhuchanda Kaur, needs no introduction. So I request chairperson to start the proceeding.
Without further wasting time, I request Dr. Rajadhar. He is a very known good speaker of Calcutta, and his subject is immunity and comorbidity. Immunity is very much important for our survival. There are two types of immunity. One is innate and another is adaptive. The adaptive immunity is a newer one developed in the vertebrate, and there are many comorbidity we have, such as diabetes and obesity, in which this immunity is influenced. So without further wasting time, I request Dr. Rajadhar to begin his speech.
Good evening, friends. It gives me great pleasure to be a part of the ICP First Conference West Bengal chapter. My heartfelt thanks to Dr. Jyotirmoy Pal, Dean ICP, for having invited me to be a part of this August gathering. It's also a privilege and an honor to be speaking in front of Professor Sukumar Mukherjee, Professor S.B. Ganguly, and Dr. Madhuchanda Kaur, who are chairpersons for this session. My topic for today is to speak about the correlation of immunity and non-communicable diseases. My conflict of interest here is that this session has been supported by Abbott, which has an interest in immunity, and some of the slides have also been provided by them. However, the academic content is in line with my thought process about the linkage of immunity and non-communicable diseases. In the next 17 odd minutes, I'm going to talk about the burden of common non-communicable disease in India. I'll talk about the correlation between NCDs and micronutrients. I'll talk about the impact of NCDs on vitamin C status, the correlation between non-communicable diseases and its effect on immunity, the effect of the immune system in the aging population, and the requirement for boosting immunity in patients with non-communicable diseases. First, the impact. And all of you know that the impact of NCDs in India today is huge. The numbers there tell you how huge this is. Non-communicable diseases kill 38 million people every year in India. The four most common causes are cardiovascular diseases, which constitute about 40% of that number. Cancers come in next. An increasing number of respiratory diseases come in last, second, third, and then last but not the least, diabetes. And you would know that we are the diabetes capital of the world. So cardiovascular disease, cancers, respiratory disease, and diabetes form more than 70% of that 38 million that we spoke about. Is the impact increasing? Yes, it is. And these two pie charts tell you that. I want you to look at the blue portion of the pie. In 1990, about 30.5% people were impacted due to non-communicable diseases, 30.5%. Compare that with 26 years later, so less than 3 decades later, the percentage of people who are impacted by non-communicable diseases has risen from 30.5 to 55.4%. That's a whopping 83% increase. So that's the effect of non-communicable diseases on morbidity in the space of less than 3 decades. So that's the burden. What's the link? Poor diet, it's hypothesized, is the biggest contributor to non-communicable diseases across the world. The reason for this correlation is both due to the non-communicable diseases and also because of the medications we use in trying to combat the effect of these non-communicable diseases. The micronutrient deficiencies increase the incidence and the severity of these diseases. This lovely picture gives you an idea as to why this is. Let's look at a few factors. You can see on my cursor there, the interaction between the drug and the nutrient. The potential pathways by which a drug might reduce the effect of the nutrient are there in the box below. There might be micronutrient antagonism. There might be induction of the micronutrient metabolizing enzymes. There might be inactivation of digestive enzymes. There might be damage to the oral mucosa or to the intestinal flora. And there's many other causes in that box. However, what's important is what's the outcome on micronutrient balance. There's impairment of micronutrient metabolism or endogenous micronutrient synthesis. There's increased intestinal renal excretion. There's impaired absorption and other factors. So on one hand, you've got pathways which cause the drug to have an effect on the micronutrient, and then you have the outcome, which is invariably a reduction in the level of the micronutrient in the human body. Let's now give you a few examples. Let's start off with the example of ACE1 inhibitors. ACE1 inhibitors cause a reduction of zinc in the body. Zinc, as you know, is an important micronutrient. This results from a reduced availability to the cell, so reduced availability of zinc to the cell, and also increased renal elimination. Which is the population which is more susceptible? It's the aging population, it's people with diabetes, it's people with heart failure, people on thiazide diuretics, people who are in an institution who have the effect of ACE inhibitors causing zinc deficiency. So if you think about it, this is the population where you would prescribe an ACE inhibitor, right? So that's the effect. Let's take another example. Let's take the effect of proton pump inhibitors. Proton pump inhibitors result in reduction of a lot of micronutrients. There's vitamin B12, there's vitamin C, and there's iron on that particular chart. And all of these micronutrients are reduced due to reduced absorption. The population who got affected, again, are the population that you see in your clinic and you prescribe proton pump inhibitors to. It's the aging population above 60. It's people with Helicobacter pylori infection, with hypochlorhydria, vegans, elderly, iron deficient patients. All of these people are individuals who would have multiple micronutrient deficiency when you prescribe them a proton pump inhibitor. There's other common drugs like acetyl salicylic acid, metformin, etc., which have effect on other micronutrients. So when you prescribe a drug to your patient, the high-risk population, the aging population, think because you might end up causing micronutrient deficiency, which might result in problems that we have just discussed. What's the impact of NCDs on vitamin C status? So let's have a look at a few NCDs. So diabetes and vitamin C, we know for a fact that people with diabetes have at least a 30% lower concentration than people who have no diabetes. There are multiple causes of low vitamin C in diabetic patients. The first is a high level of oxidative stress, which is caused by hyperglycemia. The second is due to antagonism of glucose absorption. The reason this is because vitamin C is structurally like glucose and it competes with glucose for transportation to the cell. Also important that hyperglycemic patients have reduced cellular vitamin C uptake. So replacing vitamin C in patients who have diabetes results in reduction of end organ damage. The reason for this is that vitamin C is an antioxidant. It inhibits intracellular accumulation of sorbitol, and it reduces glycosylation of protein. So that's diabetes. What about cardiovascular disease and vitamin C? So diseases like cardiovascular disease, hypertension, etc. So similar set of population, again, have a lower average vitamin C concentration in the hypertensive population as opposed to the normotensive subjects. In subjects who have systolic and or diastolic hypertension, vitamin C levels are also correspondingly reduced. In patients with hypertension and cardiovascular disease, you have endothelial activation, oxidative stress, increased inflammation, vascular smooth muscle dysfunction, atherosclerosis, etc. The antioxidant defense mechanism in these individuals is also impaired, and these patients have a greater than normal response to oxidative stress. So if you give these patients vitamin C, it helps in scavenging free reactive radicals and oxides, helps production of nitric oxide, and helps improve vascular endothelial function. So that's cardiovascular disease. The next is obesity. Again, the prevalence of vitamin C deficiency in overweight and obese people is much higher than that in normal subjects. And obese people correspondingly consume less of vitamin C. So think about it. It's patients with hypertension, patients with diabetes, patients who have cardiovascular disease who are obese. So often you have a conglomeration of these risk factors. You might have metabolic syndrome, which all adds up and results in more micronutrient deficiency and more vitamin C deficiency. What about the effect of diabetes on immunity? All of you know that diabetes results in more infection. So people with diabetes will have more infections as compared to people without diabetes. What's the reason for this? The reason for this is that diabetes impacts both the humoral immunity and also the cellular innate immunity. This results in decreased function of various cells in the body, which results in chemotaxis and phagocytosis. When we talk about various cells, we're talking about monocytes, macrophages, and polymorphonuclear cells. With obesity, we have a similar effect on the immune system. Obese people, especially people with central adiposity, will have a chronic low-grade inflammation. Persistent stress and inflammation results in adipocyte apoptosis and the release of chemotactic mediators. What's the effect in the aging geriatric population? In the geriatric population, beginning from the 6th decade of life, the human immune system undergoes a dramatic aging process, which is called immunosenescence. What's the effect of immunosenescence on the immune system? It results in weakened antimicrobial immunity. Interestingly, there's an impaired response to vaccination. So if you vaccinate the elderly for diseases like pneumonia, influenza, etc., and if these people are vitamin C deplete, the effect of vaccination is going to be lesser. And supplementing vitamin C before you vaccinate might be useful for this population. In the aging population, there's insufficient protection against malignancies. These people are predisposed to unopposed tissue inflammation, and there's impairment of wound repair. Think about it. In these individuals, you have an effect which starts off from the top, starts off from the brain, and goes down to the gastrointestinal system, to the skeletal system. However, the greatest effect is on the pulmonary and on the cardiovascular system. So pulmonary, we have said already, there's increased susceptibility to infection. In the cardiovascular system, there's increased atherosclerosis, there's increased coronary heart disease, and there's aberrant cardiac modeling. So all of this put together means that there's need for immune boosting. And the causes are manifold. Patients with NCDs are vulnerable to recurrent infections, as we said. These recurrent infections result in micronutrient deficiencies. Infections, especially recurrent infections, can worsen prognosis in patients with NCDs. And thus, in this group of patients, there's a need for immune boosting. And how would you do that? It's simple. Well, it's simple saying it, probably more difficult to do. What you need to do is to have a balanced diet. And there in front of you, our diet, which is balanced, which all of you, all of us should take on a regular basis. Sleep is important. Sleep hygiene is important because it reduces oxidative stress. It reduces the low-grade inflammation that we spoke about a little while ago. And a healthy lifestyle, exercises, losing weight, maintaining a proper BMI is of utmost importance. And in some subjects, especially the high-risk population, the population of patients who've got non-communicable diseases, that's the population of patients. But in addition to diet, at least short period of supplementation, giving the micronutrients we spoke about a little while ago would help in the long term in maintaining healthy living. So that's what we need to do, healthy living, so that the effects of aging, the effect of non-communicable diseases on the human body is reduced and we live healthily long after. Thank you for listening, and I hand it over to the panel of chairpersons. Thank you very much for having me.
Thank you, Dr. Rajadhar. So we have learned a few years back that inflammation is the crux of obesity, cancers, and now we have got a brilliant exposition on micronutrient role in all these non-communicable diseases. I don't think there are any questions because we are running very late. Thank you, Raja. Thank you for the wonderful lecture.
Thank you, Mujitanga. Thank you, Dr. Ganguly.
So we go on to the next speaker. Dr. Shekhar Chakraborty is there.